طبعا زي ما حضرتك قلت هو موضوع مهم والحضور امبرسيف. يعني احنا طبعا مشكلتنا الاساسيه دلوقتي ايذر في الاوروفارنجيال ليجنز السيرجري بتبقى مكان very narrow and to reach with effective instrumentation and effective visualization هو ده بيبقى التشالنج. انا اسف اذكرها طبعا اكنولج المؤتمر واكنولج استاذتنا الدكتوره لبنى ان احنا يعني ادتنا الفرصه. طبعا يعني زي ما استاذنا قال ان احنا عندنا الامبيشن مهم جدا، الباشن هو اللي بيخليك تبدا، الهوب زي ما الدكتور احمد امام كان لسه بيقول ان انا بفضل بريزيستنت افضل عشان اعمل محاضره واحسنها واجودها، ده بيوصلني. وطبعا لو بلان اي didn't work انا ما عرفتش اتعلم مثلا الروبوتك لازم اسافر، لازم اخد كورسز، وفي 225 حرف تاني بلان غير بلان اي. واهم حاجه طبعا نيفر جيف اب، يعني نيفر جيف اب ده مهم جدا. طيب احنا طبعا ان ذا نيكست 10 minutes احنا هنتكلم على حاجه يعني دي ولادي بياخدوها في اعدادي اللي هو الديزاين سايكل. يعني انا عندي مشكله دلوقتي، اول مشكله بتظهر عندي انا لازم ايدنتيفاي البروبلم الاول، لازم النيد، لازم الموضوع يبدا بالنيد. انا مش عارف اوصل للبروستات ان انا اعمل راديكال بروستاتكتومي غير بانسجن كبير، انا مش عارف اوصل ان انا اوصل للتانج بيز غير بانسجن كبير اللي هو كوماندو اوبريشن القديم يعني اللي اساتذتنا عارفين. فببدا اديفلوب الايديا وبعد كده كرييت السولوشن وافضل ايفالويت السولوشن. عشان كده ان احنا بنقول ايه، بنقول ان احنا عندنا ريسنت تريتمنت اوف ريسنت ابروتش تو، دايما في كلمه ريسنت وتفضل موجوده على طول. يعني ايه روبوتك اصلا؟ الروبوتك ده ان احنا بداوا اول روبوت اتعمل، السيرجيكال روبوت اتعمل على الاسترونوتس. ما كنا عايزين نعمل عمليات للناس في الفضاء، فبدانا ان احنا نوصل الناس في الفضاء والمركز اللي موجود على الارض هو اللي بيعمل لهم. وروبوتك سيرجري زي ما بنقول بارادايم شيفت، يعني هو الفكره انت الاساسيه بارادايم شيفت، ان انا بقى عندي تغيير في التفكير من الجراحه العظيمه العنيفه والاستاذ اللي هو بقى لحد ما بدا يتكون خبره ايده بدات تترعش. هي دي الحته المشكله، وبدا يبقى بريس بايوبيك، هي دي مشكله فعلا. فانا عايز حد انا اعمل له الاستراتيجي وهو يعمل اوبريشن، لان دايما عندنا تكتيك وعندنا استراتيجي وعندنا اوبريشن. ان انا اخد مايكرو سيرجي، ان انا اخد غرزه 11 زيرو واخدها اوصل فين بفين، مين اللي هيعمل كده؟ حد يكون تريند. مين اللي هيكون تريند؟ يكون اشتغل كتير فيكون كبر فتكون ايده بتتهز. هو ده الحته النيد اللي بيملاها الروبوت. والدكتور احمد برضه هيقول لنا طبعا احنا كنا زمان بنعمل الكوماندو اوبريشن، كومبايند مانديبيلوتومي ونيك ديسكشن، ده كان بيبقى المنظر. لماذا؟ انا عايز اوصل للتانج بيز، عايز اوصل للابيجلوتس. لا احنا دلوقتي هنبدا نتحرك ناحيه الروبوت، نبدا نتحرك ناحيه الروبوت زي ما احنا هنشوف دلوقتي. زي ما قلنا انهانسد بريسيجن، اكسبندد فلكسبيليتي، والكنترول والدكستريتي امبي ديكسترس، ان هو ايديه الاثنين يمين، الروبوت ايديه الاثنين يمين. الجراح دايما ممكن يبقى يوني ديكسترس، ايده اليمين احسن من ايده الشمال، انما الروبوت ايديه الاثنين زي بعض، ايديه الاثنين فيري بريسايز. زي ما قلنا المينيمال انفيزيف بروسيدور بيافويد كونسيرن اباوت فيجواليزيشن دامج لفيتال ستراكشرز اند ليميتد افيلابيلتي اوف افكتيف انسترومنتيشن. هو ده الروبوت النيد اللي الروبوت ظهر فيه. بعد ما بنظبط الديزاين سايكل بنظبط النيد كوست دايليما، ان هو ده بكام وهيفيد المريض بايه وهيفيدني بايه. هي دي الفكره الثانيه. ده السيتنج بتاع الروبوت، ده السيتنج بتاع الروبوتك سيرجري، وده كان موجود يعني كنا في عين شمس التخصص يوم الجمعه اللي فات، بس طبعا مش اوروفارنكس ولكن شغالين على لاباروسكوبي المسالك والنسا والجراحه طبعا اساتذتنا. ده المنظر يبقى موجود، ده السيتنج بتاع العمليه، ده المريض وده الاسيستنت وده هنا الكونسول سيرجن. المين سيرجن بيبعد عن العين 20 فيت، وده حاجه جديده علينا ومش واخدين عليها. طيب بدل ما المنظر يبقى كده، احنا هنشتغل كله ترانس اورال روبوتك سيرجن. الادفانتج بتاعتها ايه؟ بقلل الكوزمتيك ديفورميتي، ان انا مش لازم افتح الماندبل، والبلاد لوس طبعا، والبوست اوبراتيف بين، وطبعا الوند بكل مشاكلها، برضو العيان ده باولد ايج ودايابيتك، والريتيرن للسبيتش والسوالينج فانكشن، وبيقعد في المستشفى اقل، والريكفري اقل، والريدكشن لينث بتاع الجنرال انستيزيا. تمام؟ طيب برضو الروبوت زي ما قلنا ده المنظر اللي بيبقى موجود. الروبوت بيقدر يوصل لاماكن هيدن غير ايد الجراح. ايذر الكلام ده هيبقى موجود طبعا في البلفس عند اساتذتنا في البروستات، او احنا عندنا في الاوروفارنكس، او في التانج بيز. انا لقيت فيسل فتح هنا سوبير ثايرويد ارتري، لقيت اللينجوال ارتري فتح هنا في الدبث. طب هجيبه ازاي؟ افتح الماندبل ولا الروبوت يقدر يخش وهو ايديه الاثنين يقدر يجيب لي زوايا 270 درجه انا مش هعرف اجيبها بايدي. طيب نفس الكلام قلنا مينيمال انفيزيف ابروتش، الفاست ريكفري وريديوس كومبليكيشن. مهم جدا السلايد دي. السلايد دي الاكياجي موديل. يعني ايه الاكياجي موديل؟ كل اولادنا انا عايز اشتغل يوتيوبر، انا عايز اشتغل انفلونسر، انا عايز اعمل اعلانات لمخدات. طيب يا حبيبي ماشي، دي اسمها هوايه، انت بتعرف تعملها وبتحبها، ما اختلفناش، دي اسمها هوايه، ما ينفع، بس الدنيا مش عايزاها، الكون مش عايزها، دي مش حاجه نافعه. الحاجه النافعه يا تبقى ميشن لو انت بتحبها، يا تبقى فوكيشن لو انت بس يا دوبك بتقبض عليها. طبعا احسن حاجه في الدنيا ان انا اكون محترف في الحاجه وبشتغلها وبعرف اعملها كويس وبحبها، اللي هو السنتر بتاع الاكياجي موديل، اللي هو هنوصل لها احنا، الله اعلم هنوصل لها ولا لا. ده مهم جدا ان انا ابقى عارف ان انا ما هي الهوايه وما هي المهمه وما هي الوظيفه وما هو الاحتراف، اللي هو الاكياجي موديل. ممكن اعمل كذا حاجه، انا اكون استاذ في الجامعه بس بحب مثلا اسافر كتير وبقبض على الكلام ده، بس الدنيا مش عايزاها. يعني ساعات بنبقى احنا نعمل كذا حاجه. ايه اللي جاب الكلام ده في الموضوع الروبوتكس؟ اللي هو الراجل ده، او الراجل ده قاعد بعيد عن الجهاز، بعيد عن المريض، تمام، ثم خلاص ظبط، قاعد بيقعدوا من 20 ل 30 مينتس يظبط الاوروفارنجل الهاندلز بتاعت الروبوت او البورتس بتاعت الروبوت، تمام، وهيبدا يمسك بقى بالفيديو جيم او يمسك بالكونسول، سيرجيكال كونسول، خلاص، والنيرس قاعده، تمام. ده طبعا ده نوع، والروبوت هتلاقيه بيتحرك لوحده. ده النوع اللي هو اسمه دافنشي. دافنشي ده الاف دي ابروفد، وده اللي هو ده شغال دلوقتي على التانج بيز. الكلام ده طبعا للي عارف الكلام ده، الموضوع ده فيري ديفيكالت سيرجيكال، فيري ديفيكالت، من غير ما اعمل اكستندد مانديبلوتومي او اعمل اكسبانشن او افتح الانسجن جامد او التانج هيضايقني. انما الراجل زي ده هيعمل عمليه في التانج بيز او في الابيجلوتس او في السوبراجلوتس او في اللارynx، والموضوع بيخلص، وبيقلل الهوسبيتال ستي، وبقلل القعده في الرعايه، وبقلل الوند انفكشن، وبقلل الكلام ده كله. وده الايه؟ ده الروبوت، ده الحلم بتاعنا. طبعا الدافنشي واف دي ابروفد اللي موجود عندنا الفيرسوس لسه مش نوت يت اف دي ابروفد. طبعا الكلام ده هل سكسس، هل نصب، هل لسه؟ طبعا الايفيدنس والعلم بيمشي ان شانكس نوت ان ليبس. يعني احنا الاول حاجه بنعمل ستادي، وبعد كده نعمل سيستماتيك ريفيو، وبعد كده ننزل في بانل. البانل طبعا اساتذتنا عارفين الكلام ده كويس، البانلز الامريكاني دايما بنزين، الجديد، الفرقعه، الدواء الجديد، الروبوت، ودايما البانل الاوروبي اللي هو الانجليزي بالذات ده فرامل الطب، حتى ايام الكورونا، حتى ايام الفاكسينز، حتى ايام اي حاجه. فاحنا لسه الموضوع مش ما نزلش في الكتاب بتاعنا، فبالتالي لسه ما بقاش ابروفد في البانلز العالميه، ولكنه طبعا البانلز الامريكاني كلها طبعا طايره في السماء بالموضوع ده، وخصوصا الدافنشي. طيب طبعا الايفيدنس بيتحرك دلوقتي ناحيه ان انا، طب واي نوت روبوت عشان غالي، واي نوت روبوت عشان تايم كونسيومينج، واي نوت روبوت عشان عندنا ليرنينج كيرف عالي، صعب قوي ان انا ابدا اتعلم وكوست على العيان جامد. فلازم نقول حاجه ثانيه اسمها نيد كوست دايليما. نيد كوست دايليما، ان انا احرك العيان من المنطقه دي للمنطقه التانج بيز، لازم يكون في كوست، لازم يكون في نيد محترم. طب هل الكلام ده في الكانسرز بس؟ لا، احنا ممكن في امراض بنعمل التانج بيز ريدكشن في حالات السليب ابنيا، وده طبعا اي ما نتكلم على التانج يبقى احنا بنتكلم على حاجه فاسكولار تيديوس، فاسكولار نارو، حته فاسكولار وحته مزنوقه، يبقى لازم اوي البنفيت اجينست التشالنجز. وده مهم ان انا اقول بانهانس السيرجيكال اوتكم، وبانهانس الفاينانشال بيردن اللي موجود عندي، ان انا بقعد العيان دبل ايدجد سكالبل، ان انا بقعد العيان في المستشفى قليل بس بدفع له فلوس كتير. ودي الحته الزنقه اللي في الروبوت عموما، اللي هو كواليتي كوست او نيد كوست دايليما. نيد كوست دايليما. طيب احنا ماشيين فين في الروبوت؟ احنا دلوقتي ماشيين، المفروض ان هو في الاثنين اجهزه اللي موجودين، سواء جهاز الدافنشي اللي هو الاف دي ابروفد او الجهاز الفيرسس الموجود عندنا روبوتك سيرجري. احنا دلوقتي بنقرب كولكتيفلي ستيريل ايفوليوشن. احنا دلوقتي المفروض ان يكون التطور جامد ناحيه الروبوت. وده طبعا زي ما احنا بنقول، هل التطور ده وصل لنا احنا؟ هل التطور ده وصل لنا احنا ولا لسه؟ هو ده الفرق بالظبط بين الفنان توم هانكس الاستاذ فؤاد المهندس، اللي هو ده الروبوت اللي موجود عالميا، وده الروبوت الموجود عندنا. قدامنا حبه، لسه قدامنا حبه لحد ما ان شاء الله الموضوع يشتغل معانا. وبس طبعا لما نوصل ان شاء الله للتوب هيبقى الموضوع الطف كتير باذن الله تعالى، والمنظر يبقى احسن. دايما ان انا كاباسيتي تو ليرن، اللي هو اللي احنا بنقول عليه دايما، المثال اللي انا بقوله حتى لاولادي، مين افيد الاهلي، حسام عاشور ولا عماد متعب في تاريخ الاهلي؟ طبعا حسام عاشور. ان انا ابقى جراح محترف عالمي بس دماغي مش معايا، بهرب بسافر بهاجر ولا ان انا ابقى جراح متوسط ومثابر. هو ده بالظبط اللي احنا عايزينه، ان انا عندي فيه الجفت ان انا القط الحاجه بسرعه، اعمل العمليه من اول مره. احنا مش عايزين ده. انا عايز ان انا ويلنس تو ليرن، هو ده التشويس، هو ده الحاجه اللي احنا، ان انا عايز البرزيستنس، مش عايز الساحر. عايزين حسام عاشور، مش عايزين عماد متعب. and thank you.
ثانك يو دكتور انس، فيري امبرسيف. انا شخصيا استفدت منها والله، وحاجه محترمه. ربنا يوفقكم. ثانك يو فيري ماتش. شكرا.
طب استاذ الدكتور حازم احمد يعني مشرفنا طبعا النهارده، وهيكلمنا عن a very important topic في النيوروسيرجري، هو navigation in brain and spine surgery, a long journey towards an important milestone. اتفضل حضرتك يا فندم. شكرا.
بسم الله الرحمن الرحيم. I'm honored to be with you, four of you, five of you. الحقيقة فعلا السيشن من الحاجات المهمة، والانوفيشن ده من الحاجات المطلوبة for the next decade coming. Today I will speak about our journey, long journey in neurosurgical department of NCHAMS to reach an important milestone through navigation. We speak today about the neuro and the spine navigational surgery. Before the navigation, it was like this, you know, sometimes you feel that you're lost inside the operation and you don't know what to do. So could you go to click to the internet and look where you are? Now it's easy with the navigation. Neurosurgery is a complex specialized field that needed to be advanced, that needed to be precise in the treatment and the surgery, and that's what makes us go into the navigation. And the navigation system provides the surgeon real-time 3D images of the patient anatomy, which can help to improve the accuracy and safety of the surgical procedure. The navigation of the brain, it's like the GPS of the brain and the spine. How it works? You need to have the localizers, like the satellite, and the instrumentation or the coils where you can detect where your instruments is, and the patient images, which is the maps itself. All of it integrated, you go to the navigation. The navigation principle is by preoperative planning first. You first take the scanning and put it into the software of the computer, and then you do the registration, and then you start the navigation and finishing the procedure. You can divide it into a preoperative and intraoperative. The preoperative is the navigation system charting the course, and the intraoperative is the real-time guidings. We're reaching the destination where you want safely. But why cranial navigation if we are going to speak? Because it's important, delicate, it's deep, and it's very important areas of the brain. We start the navigation by localizing the point first by something called stereotaxy. Most of people, they misunderstand the stereotaxy with the navigation system. The stereotaxy, actually, it's a technique we used 20 years ago in NCHAMS, which precisely locate the specific three-dimensional point, as if you are pointing into the map. But if you want to navigate to reach this point, then you need the navigation. Even though the stereotaxy now offers a targeting method, while the frame-based navigation built upon and can be used to reach with safety to your point. The type of the navigation system, it's a frame-based and frameless-based. We have the frameless system, which is the brain lab, spine navigation, and neuro navigation. This employs an advanced tracking technique to provide the surgeon a real-time guidance during the spine procedure and the cranial procedure. There is two kind of the navigation systems used all over the world, the brain lab and the Medtronic. They depend on the optical and the electromagnetic tracking method and the infrared camera, and the electromagnetic coils, which is the detector on the machine, on the instruments you are using. Both of them giving tracking accuracy very high and real-time guidance. What are the application we are going to use for the navigation in the cranial? The brain tumor resection, aneurysm clipping, functional surgery like the epilepsy surgery and deep brain stimulation surgery for like the DPS for the Parkinson, and the pituitary tumor surgery. What's the benefit? Enhancing accuracy, precision, minimizing the damage, enable the access to the deep-seated, and also improve visualization with a critical structure next to the lesion, reduce the surgical time and the bleeding, potentially leads to a better patient outcome. Here the deep-seated lesion, you can see a patient with posterior horn intraventricular lesion, deep-seated. And this with the join of the ultrasound, and you can detect, and first you navigate by the navigation, the cranial navigation, and assisted by the ultrasound scanner intraoperative, we can detect the lesion and you can visualize a proper lesion, and you can see the tissue of the lesion itself. So you can resect it. Here the location, how you, here after opening the dura and after the excision. But what the controversies for the neuronavigation mainly started by the glioma resection. Glioma actually, it's a very questionable field for the neuroplastic tumors, because when we grow up, most of our professors far away, 10 years, 20 years before, they say, don't do anything, just give chemotherapy. But now, thanks with the intraoperative neuromonitoring, thanks for the neuronavigation, we can go to a resection, reaching to a total resection for the tumor. Here, a lot of literature that evaluating the neuronavigation for the glioma surgery and the frequency of the gross total resection in the glioma patients. Not only for the glioma, but also for relocant areas of the brain, the important areas of the brain, like the brainstems. Brainstem gliomas is very crucial, and usually there is an incidence of affection, there is usually incidence of morbidity, like cranial nerves affection or injury. Usually with the neuronavigation, it's less. Not only the brainstem or deep-seated, but also the small lesions where it's surfacing. It's very easy to detect the small size by the neuronavigation. And also, it's very important as a neuronavigation for the cranial with an MDT, with a multidisciplinary team. Here we are removing with a plastic surgeon as a team, medial sphenoidal wing meningioma affecting the orbit, and we are actually reconstructing the orbit with the navigation, with a complete resection. What about the, you can say, a longer journey to reach, but shorter we started? spinal navigation. We started the spinal navigation at NCHAM's department, University Department of Neurosurgery, at November 2023. It was a long way to convince people about the navigation in the spine. Even it's much difficult than the cranial part. But why? Why? Because people used to fluoroscopy since 1940s. And the fluoroscopy can give you superior imaging rather than X-ray, normal X-ray, and cheaper than the navigation. What are the types of the navigational spinal surgery system? It's a fluoroscopy based or image guided system. What we have in our department, it's an image guided system, not a fluoroscopy base. What we are using is a brain lab. The future is the augmented reality system, where these systems overlay a digital image of the patient anatomy into the surgeon fields and to help them to guide the surgical instruments. Why we should use navigation in spine? A lot of people will ask, a lot of people will say it's a gray zone, it's a gray area. Why? It's easier to do without, it's much expensive, and as my colleague Dr. Anas mentioned in the previous lecture, it needs a learning curve. Navigation system can help to improve accuracy and safety, reduce the risk of the complication, shortening the time, and one of the most important points in the spine surgery, that it's decreasing the risk of radiation exposure to the surgical team, anesthesia, and the patient itself. Why? What we are using the navigation in: degenerative disc disease, herniated disc, spinal stenosis, spondylolisthesis, scoliosis, kyphosis, spinal tumors, any open surgery. And I again insist this is an open surgery for the spine, because later the navigation give us a very important rule and hand on the minimal invasive. This is the screw placement. Here in the vertebral body augmentation in the fracture, you can direct your needle and do the vertebroplasty and inject the cement very safely. Spinal decompression system. In November 7th, this 2023, actually not 2024, it was the first case in the Demirdash which was advanced multiple level of spinal canal stenosis with a spinal instability. And here the team who actually did the first operation in the spine navigation in NCHAMS. I will let you see how marvelous the screws insertion. It's a mirror image. Very impressive. Then we started a week later, the first, not only in NCHAMS, but the first in Egypt, to do navigation for the scoliosis, for advanced scoliosis. Here, it gives you a superior for the distorted anatomy, a superior localization for the distorted anatomy, especially for the apex of the scoliosis, where the angle is. It's really helped me a lot, and much better. You can see the correction completely. Now we go to the golden rule for the navigation with the minimal invasive surgery. Why it's minimal invasive? It's less invasive, that minimizing the tissue disruption and decreasing a collateral damage while achieving our aim. It's percutaneous fixation, spinal stenosis decompression, and vertebral augmentation. It making less pain, shorter hospital stay, faster recovery, and improving cosmetic outcome. You can see the scars on the back of the patient. It's just 1 centimeter over each screw. But as I say, it's ideal for revisions because distorted anatomy, the spine navigation is superior. Here how we plan. This is the drill. The orange one is the tip of the drill, and the red square is the marker or the detector for the drill, and the green one is the screw, and then the low speed, high torque power drill in the yellow one. I will go through this very fast as much. We usually use the intraoperative neuromonitoring, which is very important to detect any problem in the root or the affection of the nerve through it. Here you can see calibration. And this is the X-ray before the operation. You can see this is a high-grade spondylolisthesis. Now with the navigation, just you can put the screws very safely. You can put even a cage. And finally, you can see a correction with the complete decompression and very small incisions. Operative time took 2 hours, bloodless 150, post-operative day 1 day only. What we are doing for our department, we continue to educate, we continue to make awareness, and this is a continuous training for our team, for the juniors. And not also like this, but we encourage them to put it into a thesis and publications for the navigation in the spine. Do we have any challenges? Yes, we have challenges now and challenges ahead. High-cost neuronavigation system, integration with the surgical workflow. You need to train not only the surgeon, but all the surgical team, continuous improvement of the image and registration technique, and development of the AI-powered navigation. But through 2021 to 2024, the awareness increased between the doctors and the patient, the usage of the navigation increased, indication increased, variety of cases increased. What we should know, navigational brain and spine surgery improve surgical procedure, help to improve accuracy and safety of the surgical procedure and reduce risk and complication. Improve patient outcome, such as less complication, rapid recovery, and pain relief and function. The exponential growth of the technology is very essential for the navigational technology that continues to evolve, so we can expect to see even more benefits in the year coming with the development of the AI. Thank you very much.
Thank you, Professor Dr. Hazem. A very nice presentation, and it was very interesting to know that these innovative surgical techniques are being done, especially at our lovely Demirdash Hospital. Again, thank you very much for this nice presentation. Thank you.
Next, Professor Dr. Ahmed Imam from Urology Department, Neurosurgery Department. Progress in robotic surgery and urology in Shams experience.
Good evening. So it's my pleasure to be here today. In brief, I'm Ahmed Imam, an assistant professor of urology and the head of robotic surgical unit at Ain Shams University Specialized Hospital. So I was honored to be the first head of this emerging unit, that's robotic surgical units. I had 2 years of clinical experience at Roswell Park Comprehensive Cancer Center at Buffalo, New York. I also have completed all USMLE steps and had this clinical experience. So I will talk in brief because I can see we are nearly late, and most of the audience are not urologists, so I will just talk like a general idea about how the robots are working, and in summary, I will present a short video about a live surgical operation that I already did at Ain Shams University Specialized Hospital. So this is the Da Vinci robot. The system is manufactured by the company Intuitive Surgical. The FDA cleared the Da Vinci surgical system in the year 2000 for adult and pediatric usage in urologic, general surgery procedures, gynecologic, thoracoscopic procedures, and thoracoscopically assisted cardiotomy procedure. So this is the console and the robotic surgical unit. What we got at Ain Shams University Specialized Hospital is this version. It's called CMR. CMR Surgical is a British medical device company based in Cambridge. So it's Cambridge medical robotic system. This is CMR. It produces a robot-assisted surgery system called Versius. So the main difference between this robotic unit and the other one, that's Da Vinci, is here the robotic surgical units are separate. Everyone is a separate unit, and the console here is an open console. While in Da Vinci, you put your eyes inside the console. Here, you just wear 3D glasses and you see the vision. I will show you in briefly. This is our surgical room. We use OR10 at Ain Shams University Specialized Hospital. So it's fully equipped, and this photo is like a 3D photo through a glass, through the 3D glasses. So here I'm working on the console, and this is our surgical team. The controls of this robot we have at Ain Shams University Specialized Hospital is very simple. In brief, you have two hands like a joystick, and you can just with the right and joystick, with your right index or left index, you can open or close the jaws of the instruments. These big buttons are called the clutch button. Clutch button يعني ببساطة بشبهها زي الدبرياج بتاع العربية المانيوال. انت لما بتدوس عليه ممكن تحرك ايدك من غير ما الحركة دي تتنقل للآلة اللي جوه بطن العيان. دوست الدبرياج بيتحرك بعد كده من غير ما الحركة دي تتنقل على جوه بطن العيان. وبعد كده في energy button on the right instrument, the diathermy, and another one on the for the left instrument. Okay. So let me just present as case. This is a 40-year-old male patient having right upper polar renal mass. It's marked here with a pen. So this is right upper polar renal mass. The mass is big and it's encroaching on the renal pedicle. So usually if you are going to do in open surgery, you can do either radical nephrectomy, or laparoscopic nephrectomy would be very difficult using the laparoscopy. Here I used the robot to do a robotic right partial nephrectomy. So it's a very advanced surgery. As you can see, the vision is very clear. It's a very sharp vision. So here, this is the liver. I'm putting a liver retractor because it's the right kidney. I'm just opening the gyrus fascia. It's surrounding the kidney. This is the kidney. You can see the bulge of the mass. It's at the upper pole of the right kidney. So clearly the vision is marvelous with this robot, and a better vision will give you definitely a better surgical outcome. So I'm here dissecting and clearing some of the fat overlying the upper polar right mass. I will just skip some parts because I'm just showing you the idea. Don't need to say, to. So here the upper polar renal mass is dissected. I'll just put a vessel loop. This is the big renal vein. This is the renal vein, and it has three big tributaries, one tributary, another, and the third tributary. Here I'm putting a vessel loop behind the renal pedicle. So you can see the kidney. Clearly, this is the normal kidney here, and this is the renal pedicle, and this is the upper polar renal mass. And I just put a some control over the renal pedicle because the kidney is very vascular, and partial nephrectomy is much more complicated and much more advanced than radical nephrectomy. If I'm doing radical nephrectomy, I'm done now. I just clip the vessels here and take out the whole kidney and the surgery is done. Now I started the robotic surgery. As you can see, this is the robotic instruments. You will see it has very sharp and precise movement. I'm dissecting the gyrosas fascia out of the kidney. The first part I did was laparoscopic. Now this is a robotic instrument. Okay. So this is the idea. Actually, after the previous two lectures, I'm thinking about getting the neurosurgery department and the ENT department involved in using the CMR robot we have already at Ain Shams University. To be honest, up till now, the company says that it's for gynecology, general surgery, and urology. But if you have like some simple cases and you would like to start giving it a trial, I believe it will be very helpful. Here I'm dissecting the back of the kidney. With laparoscopy, this would be very difficult to see at this point because this area here lies between the liver and the posterior border of the kidney. But using the robot here, I'm tilting the kidney up and I can dissect it very safely. Now I'll start demarcation about demarking the tumor that I'm going to resect. As I told you, it's like a very advanced surgery in urology because you are trying to remove the tumor and preserve the kidney, and the kidney is very vascular. It can bleed so much, and also there is a collecting system. There may be also urine leakage, so you have to repair the collecting system and you have to suture the bleeding vessels in a timely manner because during enucleation, you will see in a second, we put some bulldog clamps over the renal pedicle to cut the blood supply from the kidney. So we work under, we call it ischemia, hot ischemia. So you have to be fast, and the robot helps us to be precise and fast in these steps. All of this now is without just demarking the renal tumor without the clamping. I'll just show how we put the clamp. So this is the clamp here. It's called laparoscopic. It's called laparoscopic bulldog clamp. So here, this is the ureter. This is the ureter, and this is the renal pedicle. This is the laparoscopic bulldog clamp. So, to start enucleation of the renal tumor, and then we start resecting the tumor. I can just fast forwards. And of course, like we have to go in the plane of enucleation of the tumor, the smooth plane here, and not to use the thermal energy so that not to cut into the tumor. It's the last part of the tumor. Tumor is out, and now start suturing the base of the tumor. By the way, this is the adrenal gland. This golden gland here, this is the adrenal gland. Before surgery, we put ureteric catheter so that to check the integrity. I will now inject saline from the ureteric catheter to see where to repair the collecting system. Now inject again. Yeah, we can see it's bleeding here, and this is the main privilege of the robot, to do this suturing in a timely manner because the kidney blood flow is blocked. And even though we are blocking the renal artery and vein, still there is some bleeding, but it's minor. So here the assistant is injecting normal saline from the ureteric catheter to see the collecting system that needs to be repaired. Here, yeah, you can see. Of course, if we are using laparoscopy, this would take hours, and it will not be feasible, and the outcome will not be good. This was actually our the first robotic partial nephrectomy to be done at Ain Shams University Specialized Hospital. Actually, some of my colleagues thought it's not possible using this robot, but this proves that it was possible. Then we did another 3 or 4 cases, and the last one was done also I believe last Friday. كان على هامش المؤتمر برضه ده. So in brief, after suturing the bed, we put this fibrillar and then suture and close the gyrus fascia over the kidney again. We don't leave the kidney exposed to avoid small intestine being adherent to the kidney in case we wanted to go back and do any other surgery for the kidney. It's better to return everything to its original status. So here is the gyrus fascia is now closed. We just do suction for this. This is the tumor here. We'll take it out now. So as you can see, the tumor, this is the undersurface of the tumor. It's very smooth, meaning that we didn't open the tumor. The tumor was not opened. It's intact. Now we remove the liver retractor. You will see that the liver will now cover the whole kidney and the whole part of surgery we were working upon. And this is a tumor. It was removed in a very good way, smooth surface. And this is a specimen. And the final pathology, it was 5 by 4 centimeter chromophobe renal cell carcinoma grade 2. Tumor extends into the perinephric fat, no sarcomatoid features, and most importantly, negative surgical margins. So another cases were done using, like, our colleagues in gynecology had lower ureteric injury. This is a nephrostomy, the ureter here, and it's cut here at this point because they ligated the ureter. So as expected, the renoma caused very severe adhesions of the bowel to the bladder. So the first step was to dissect these adhesions from the bladder. And most important, try to preserve the bowel loop. This is a bowel loop. If you can see, yeah, this is a bowel. So here you should cut away from the bowel. So this is, so here, like, it's uretrovesical. This is the ureter we are implanting again inside the bladder, and this is the double J ureteric catheter. Put inside the bladder and continuing to suture the ureter into the bladder. In this case, this patient is still following up with me, and the results are excellent. The ureter is nearly normal. So these are in brief some of our surgeries using the CMR robot at Ain Shams University. Okay, thank you so much.
Thank you, Dr. Ahmed, for the extraordinary presentation, surgical technique. It's amazing. Thank you very much. Thank you. Any questions? Thank you. Any questions? Thank you very much for attending. We close this session. Thank you.
The next talk will be for Professor Dr. Amr Amara, Professor of Urology and Consultant Urologist at Hemisphere Hospitals, NHS Foundation Trust in UK. Dr. Amr will present presentation about minimally invasive tools in management of prostatic enlargement. Thank you Dr. Amr for joining us. مع حضرتك أحمد إمام. أهلا وسهلا بحضرتك.
تمام، ازيك؟
أهلا وسهلا بحضرتك.
شكرا جدا دعوتي للمشاركه في المؤتمر ليك وللاورجنايزنج كل الناس الموجوده. مش في حد قاعد لسه ولا لا، انا مش شايفكم. I hope there's some people still there. I know it's quite late. Can you see my presentation?
دكتور عمرو هو الصوت بس مش واضح قوي حضرتك.
Can you hear me?
ايوه كده اوضح شويه.
Okay. Is this better now? كده سامعني كويس يا احمد؟
سامعين حضرتك تمام كويس تمام شكرا.
تمام كويس. أقول شكرا ليك وللorganizing committee for inviting me to share with this my Ain Shams, my home university Ain Shams. Always glad to be contributing with you guys. Very impressed with the presentation I had before. I actually was listening to your presentation. Very good work about the CMR. By the way, if there's people still sitting there, this is a difficult case. It's not an easy person. In fact, it's 5 centimeter upper pool. Very impressive work, and I know quite well that the CMR is not as easy to work with as the Vinci. I noticed أنا
دكتور عمرو اسف مقاطعة حضرتك، الصوت برضو رجع مش واضح تاني معلش.
مش عارف اعمل ايه. لو قربت كده كويس
بيبقى احسن تمام.
طب انا هقول لك حاجه، انا will stop sharing my can you see me or you can hear me only?
Both. We can see you and we hear you.
Perfect. Okay. Is this better now?
Sure.
This is better?
الصوت أحسن
طب كويس. I will stop my I'll come closer to the thing just a second.
Please, doctor, can you remove the presenter view?
Okay, is this better now? Can you see my... Okay, you want me to... عايز أشيل مش كده؟
Full screen, please.
Is this okay? Okay. So, can you see my screen now?
It's okay, doctor.
Perfect. Okay, thank you. So, I was just saying it's very impressive to see the other specialties work, especially the ENT. Dr. Anas, I was impressed with what they do now, and Dr. Hazem using the targeted and navigation, which we actually use in the prostate biopsy as well. وزي ما بقول كده الدكتور امام عمل برزنتيشن جميل جدا عن السي ام ار which is quite impressive. انا هاخدكم في حته ثانيه خالص، حته البروستات، والبروستات actually is a very important subject in urology. To give you a flavor كده I'll tell you ان هو I'm not sure how many male are sitting in the hall now, but if we're talking about if 20 males are sitting there, 10 of them at some point in their life will have a prostate problem. And maybe one in 7 will need some kind of treatment. So prostate is really a big problem for males. And I'm talking about the prostate enlargement, not the cancer. The cancer is a different story. In the past, we, as a surgeon, we always say, okay, you have prostate problem, come for surgery. At some point, we used to do the open surgery, and then we went to the endoscopic, and everybody's talking about the gold standard, something called TURP, which is transurethral section of prostate. I understand that many of the attendees are not urologists, and basically it's using cystoscope or cystoscopic approach or endoscopic approach through the penis to remove the core of the prostate. فتخيل كده prostate is an apple surrounding the urethra أو المجرى البول. واحنا we go and we excise the core, بنشيل الcore of the apple, and this gives people good channel to pass urine. Very good operation, very successful. However, it comes with problems, bleeding, infection, things like this. As surgeon, we think it's operation, it'll be absolutely fine. This is how we see it. This is the root. And we always tend to try to get what we call a big cavity. Imam, can you see what I'm seeing now, right?
Yes, we can
Imam.
see it, but it's not full screen. And the voice is not so clear, but we can hear it, but it's not so clear.
Okay. So is this what you see now? But what about the side effect and patient satisfaction? Is this what you're seeing?
Yes, correct.
Perfect. Okay. So what I'm trying to say is that as a surgeon, we always look at the improvement in the, or tunneling the prostate in a good way, and hopefully the fluid improve. For the patient, it's always how long I'm going to stay in the hospital, the catheter, how long is going to stay. Am I in risk of bleeding? Am I in risk of post-operative complication? Am I going to have any problem with the continence? What about my sex life? What about my ejaculation? All these things are simple in the eyes of the surgeon, but it's really not simple in the eyes of the patient. And this is why minimally invasive treatment have came into action and become really pushing its way in. And also we are affected by the industry. So these are the spectrum of treatment for BBH. Either do nothing, keep an eye, give treatment, or go very harsh and do a big surgery for the patient. But the minimum invasive actually come in the middle of this equation. And it's very attractive for the patient, very safe surgery. It can be done outside in outpatient sometime in some of these things, and very important for many patients, especially post-male patients. They are very keen to preserve the sexual function, including all parts of the sexual function like the ejaculation. And of course, it has to be rapid and durable and relieve the symptoms as quick as possible. And if I can avoid a catheter, this
دكتور
will
عمرو
be
بإذن
better.
حضرتك هو الصوت برضو مش واضح قوي.
But I'll tell you something. I am going to move into a different system of voice. Okay, just give me a second.
Headset now. Can you hear me now? Can you hear me better now?
Yeah, okay, yes.
Okay, fine. Is this better now? Yeah.
Yes, much better, much better.
Perfect. Okay, we'll go for this now. And I think I'm getting some help from your team. Thank you. Perfect. So to go back to this point, we're talking about where is the minimally invasive treatment sitting in the spectrum of overall BBH management, and it's this thing in the middle. Are you still with me? Hello?
Yes, yes, we are.
Perfect. Okay. Which is attractive to the patient, safe kind of surgery. We can do it in the office, like outpatients, and we can do it on the local. So all these are advantages that is highly important to most of the patients. If I move to the next slide, so what are our targets of MIST, which is minimally invasive treatment? Is it going home the same day, or is it a non-cutting procedure? Don't use cuts for the prostate. Or is it zero blood loss? Is it local anesthetic procedure? And to my eye, and I'm sure to the patient's eye, it's a combination of all of this. What are we using now? So as I said earlier, the TRP was kind of the gold standard, but there is a lot of things coming out now into the market. عندنا حاجه اسمها ريزيوم موجود في مصر دلوقتي. It's basically using steam to be injected. 9-second injection into the prostate, can be done under local sedation. We're talking about 2-3 minute procedure. The steam is injected in the prostate. It causes what we call tissue or cellular death. So all the prostatic enlarged cells will be absorbed by the patient and will open the channel of the prostate again. Alternatively, في حاجة تانية برضو موجودة بقى لها فترة in the market, and very minimally invasive treatment, something called Euroleft. And this is Euroleft on the right hand side of the screen. which basically we are squeezing the prostate to open the channel for a better flow of urine, improving symptoms. Lots of advantage from the uroleft. You're avoiding catheter. You're not removing tissue. It's really minimally invasive treatment, but there's always pros and cons. في حاجات تانية جديدة in the market coming, many more technologies. It's a very profitable area for the industry, and that's why they are investing a lot and giving us all these lovely toys. There's something called iTind, and iTind is basically and one of these expanding prostheses. We put it temporary into the prostate, and it opens the channel. There is the prostate artery embolization, and I'm not sure if there's any intervention radiologist, but it's blocking the blood supply in the prostate, shrinking it, and also reasonably effective, but there is some pros and cons. Latest in the market, something called AquaBeam, and AquaBeam ده بياخد نفس فكرة الجيت ووش، زي كده ما بنروح ننظف العربية عند في السيرفيس. Is the same idea. Very powerful wash, and then we can remove the tissue by this. And this is actually a robotic platform. اتكلمنا عن advantages من شويه كده عن الادفانتج بتاعت الروبوت. الروبوت فيه ادفانتج مهمه قوي، انها it actually improve the longevity of the surgeon to work. We're investing a lot of money in surgeons, and part of the investment that you keep them working for longer time. If you keep doing laparoscopy open, your time limit to work is actually not that high. At certain age, you have to stop. If you use the robotic system, you improve this and you prolong it, so you get more advantage of people. Not forever, of course. Also, the learning curve is quicker. These are advantage that is hidden from us, but it's really important. Even less invasive technologies, balloon dilatation. Now the balloon dilatation, they're putting some chemotherapy on top of it, and this is something called the optilium, a balloon in the urethra or the prostate area, dilated, chemotherapy on top. It does its work, and it keeps the channel open all the time with very promising early outcomes. Old technique but renovated, something called core therm, radio frequency. We put this inside the patient through the catheter. Again, minimally invasive, under local, and this needle here is move position within the prostate. Radio frequency, again, kill the prostate enlarged area and cause ablation, bigger cavity. Very minimally invasive technique, and more technologies coming in the field. The old stents now have been renovated in a good, in a better technology. Something coming called the butterfly, the ZenFlow. More and more minimally invasive coming.
دكتور عمرو بقى إذن حضرتك، احنا قدامنا اللي ظهر قدامنا دلوقتي سلايد نمبر 4. هل حضرتك
انا مش عارف ايه المشكلة. Number 4. أنا اللي هو ده main plays in the market, or are we moving on?
Okay.
Is it changing?
No, it's not changing. It's slide number 4.
Okay. Let me do something. I'll stop share and then share again, okay?
Okay.
Can you see better now?
Yes, now it's working. Yeah. Okay.
Okay.
Yeah.
So main player in the market, we talked about this, and we talked also, let me drop this down. Now you can see the AquaBeam.
Yes, we can see this now. Yeah.
Perfect. Okay. So you're looking now at me. Yeah. So I'll talk about the AquaBeam is actually a robotic platform for BPH using the jet steam. The same idea as we clean our cars. And then we do use the optilium, which is one of these balloon dilators, which are covered with paclitaxel, one of these chemotherapeutic agent, and you open the commissure and it keeps it open. A very good maintained channel. Early results still, but very promising. Well, core therm, again, one of the old technologies, but also can be used now. Can you see the butterfly and the ZenFlow?
Yes, we can see this. Yeah.
Perfect. We're in action then. These are investigational treatment. They are all one of these, some of the old stenting renovated in new technique. And again, more and more things coming in the market. To come, it's what is important here. Why are we using minimally invasive treatment? And how can they be successful? First of all, are they safe or not? Are they intelligible? Can we use them easily with patient? Can they be reproduced easily? What about the learning curve? Can be used for different shapes, sizes of the prostate? Versatility is important. What are the patient-reported outcomes? Is our flow improving? Is our prostate decreasing in size? Is the quality of the patient improving? How is the cost? Is the cost high, low? This is all important success or key success elements for any new medical technology. And most important, durability. You don't want to do a procedure today and the patient coming for a second procedure in 2 months' time. 4 or 5 years is not unreasonable. We know that the prostate can grow, but this is the time challenge and it's very important. And I'm moving to the next slide now. And if you have problem with the slide moving with you, just let me know. So how do we choose between different technologies? It's lots of factors there. Is it the prostate size is important? How the shape of the prostate? Is this patient having a bleeding risk, anesthetic risk? What are
Dr.
the patient
Omar,
priorities?
we're very sorry, but the time has passed 5 minutes now. Can we go
Fine.
faster,
I'm
please?
sorry. Yeah, I am going to finalize now. What I'm trying to say here so my message here is all these systems are very helpful, but we have to choose the best for patient and also the reasonable thing for the patient important. So this is some evidence about the different treatment modalities. But at the end, we have to realize that it's not only one treatment there for the patient, it's a portfolio of treatment. And we have to be quite clear with the patient that it's not only one treatment modality. We have to have this kind of open discussion with him. What is important for you? This is what we have in the market now. Some of these treatments are available locally, some of them coming in the future, but it's really important to understand the patient priorities and also to understand that we cannot just force our own vision to the patient. We have to use all the tools we have in front of us. Technologies are there for everyone. And I don't think that there is anything called standard of treatment or gold standard treatment now. It has to be a portfolio of treatments, and minimally invasive treatment is definitely one of them. Thank you for listening. And actually, thank you again for inviting me to this meeting.
Thank you so much, Dr. Amr, for this.